Welcome everyone to this session on monitoring and valuing WASH and waste care services in healthcare facilities for safer, more equitable care. I'm Ann Thomas, Senior Advisor, WASH at UNICEF. Water, sanitation, and hygiene are essential for safe, quality healthcare. Not only are these services critical to preventing the spread of infection during routine care, it's also necessary to ensure resilient services during pandemics and outbreaks. But these services are absent in thousands of healthcare facilities around the world, and particularly in low and middle income countries, putting patients at greater risk of infection. Since 2014, we've seen steady progress and interest in this area of WASH in healthcare facilities, starting with the 2018 Secretary General's call to action, and then with the 2019 World Health Assembly resolution. Meanwhile, during the COVID-19 pandemic, we've seen huge discrepancies in health systems, including lack of WASH in healthcare facilities. The growing threat of climate risk has only further exacerbated the problem. The growing momentum and increased awareness has provided a unique opportunity to strengthen national and global action as we raise awareness about the gaps in services and better us to understand the costs associated with improvement. There has been an increasing focus on value and economic gains for investment. You'll hear today that there have been recent advances in the global data set on healthcare facilities, while also there have been developments in tools that making incremental change possible in countries around the world. In this session, we'll start off with two stage-setting presentations. First, we'll hear from Rick Johnson, who is the co-lead of the joint monitoring program between WHO and UNICEF, and he'll focus on presenting the new 2022 JMP WASH in Healthcare Facilities report, and it focuses on WASH and IPC, including for the first time global estimates of hand hygiene in healthcare facilities. Second, we'll hear from Bruce Gordon, who's the head of the WASH unit at WHO, who'll then present on the recent, the recent study estimating the cost of WASH and waste management services in the 46 least developed countries. Following these presentations, we'll have a panel of experts who will share their insights on what is needed to leverage this evidence to further accelerate action around WASH in healthcare facilities. So we'll have an opportunity for those of you in the room here in Stockholm to ask questions and provide comments. And for those of you online, you're welcome to place your comments in the chat box function in Pathable. So before I turn over to Rick, we're going to share a short video that showcases some of the perspectives from healthcare workers and patients who have been directly impacted by WASH conditions in their healthcare facilities. So, do I just press it?
Pressing the space button?
Yeah, that worked great.
Jengo letu la kutolea huduma lilikuwa halina sehemu za kunawia mikono, pamoja na upande wa labor ward. Choo kilikuwa hakifanyi kazi vizuri kwa sababu ya ukosefu wa maji.
Kwa hiyo kuja kujifungua kukaa hata masaa 5 mwanamke hujapata ule usafi, ule uchafu ulofanyaje kutoka. Kwa hiyo unalazimika ukae mpaka muda maji atakapopatikana.
Kwa sababu unaangalia hata wagonjwa wanapokuwa wengi, choo cha kuingia hakipo, ndio hicho tundu moja hilo tena ni la kijiji. Siku kukiwa na mkutano ndio wanaingia huko wananchi, wanaingia huko na wagonjwa. Kwa hiyo usiri ukakosekana kabisa. Changamoto hii tulikuwa tunategemea bomba la kijiji lililoko jirani. Bomba hili linatumiwa na kijiji kizima. Kwa hiyo tulikuwa tunatoka kazini, unawahi kazini asubuhi na mapema sana. Unawahi kupanga foleni ili niweze kupata maji ya kuja kutumia zahanati.
Tumeweza kuimprove kwa kiwango kikubwa. Tumepata vyoo vya kisasa ambavyo ni rafiki kwa matumizi ya makundi yote, yani wenye mahitaji maalum, watumishi na wateja wetu wanaokuja kwenye kituo chetu hapa. Vile vile tumeweza kuweka mfumo wa maji safi kama mnavyoona hapo. Imetusaidia kwenye upande wa uviko 19.
Tunanawa mikono kama mimi ndivyo mashahidi, naona kila mahali kuna sinki, kuna maji ya kunao. tukishahudumia mgonjwa tunanawa mikono, kabla hatujamhudumia tunanawa mikono, tuna karo la kunawia nje, wagonjwa nao wananawa nje.
Dada, dakika chache tu kijisikia nguvu kidogo, unapelekwa wani, unaoga vizuri, sasa unabadilisha nguo, unakuja hapa ni mpya. Shida ya maji kwa kweli mwanzo ilitutesa sasa, lakini tofauti sasa hivi. Sasa hivi mambo yako vizuri, pata huduma kwa wakati.
Kuna wateja ambao tunawapata kutoka kijiji kingine ambacho hakina mradi huu.
Na hawa kina mama wengi tukijaribu kuangalia sio wa maeneo haya, wanatoka zahanati za jirani. Wengi wameacha kujifungulia nyumbani, wanakimbia kujifungua zahanati.
Hii imetusaidia sisi watu wa huduma kutoa huduma kwenye mazingira ambayo ni rafiki kwa huduma. Mazingira tu yakiwa mazuri, sisi watu wa huduma tunakuwa na afya ya akili unapotoa huduma yako.
Lakini tangu mradi umefika, nahisi kama nitabaki Itepula, nitaendelea kuwepo.
Great. It's always nice to start with actual people impacted by programs before we move to kind of the global picture and talk about coverage and numbers. So my name is Rick Johnston. I'm with the World Health Organization in Geneva, and I co-lead the Joint Monitoring Program along with Tom Slaymaker at UNICEF, who's also here today. And we've been publishing reports on WASH in healthcare facilities since 2019, and I'm here today to give you a sneak preview of the new 2022 report, which is being launched later today. Now, the slides are being advanced by colleagues on the Zoom channel, so Lindsay, if you could move to the next slide, that's great. Embargoed. All right, let's move on to the next one. This new report updates and supersedes the data that we've published previously, most recently in the 2020 Fundamentals First report. And that report, we just had a pretty short input, about 20 figures, but today we're launching a full-scale report with about 80 figures. Lindsay, if you could go to the next slide. The full-scale report has about 80 figures, which allows us to go into a lot more detail and explore, for instance, the inequalities that we didn't have time and space to do 2 years ago. And one thing that I get excited about in this report is that the amount of data we draw on has expanded quite a lot. We had access to over 500 national sources of data. Most of these are healthcare facility assessments, but there are also several examples of routine management information systems, or MIS, and a small number of research studies or sector reports. And together, these data sources are based on assessments of at least 933,000 healthcare facilities. That's almost twice as many as we had in the baseline report made in 2019, which had only about 260 data sources. And this report is being launched today. It's embargoed until 10:30, so just in about an hour and 15 minutes. It should be up on WHO and UNICEF websites right after this session, so you are the first people in the world to see this report today. Great. And like all, if you move to the next slide, Lindsay, like all of the JMP reports, we make use of what we call service ladders to monitor progress towards different levels of WASH services. Now, for households and schools, we have ladders for water and sanitation and hygiene. But for healthcare facilities, we also have ladders for waste management and environmental cleaning, which are both related to hygiene and infection prevention and control. So in the ladders, we define the basic service levels, and that's the highest level that we track for global monitoring. But if you can see the definitions there, and I won't read them out, the basic levels are really pretty basic. So there are definitely countries that go beyond the basic level, and we highlight in the reports examples of higher levels of service. And you can see that we also try to distinguish between facilities that have no services at the bottom of the ladder there, and those that meet some but not all of the requirements for basic service. We call that a limited service. On the next slide, this year you'll see our report has a special focus on WASH and infection prevention and control, or IPC. And much of our audience comes from the WASH sector, more WASH than health. So we wanted to point readers towards the frameworks and resources that exist in the health sector, and especially on IPC. For example, IPC speaks of 8 core components, and one of them, number 8, is about infrastructure, which includes WASH services. And they have defined minimum requirements from an IPC perspective for each of those 5 WASH service areas, so we refer to those in the report and point to other resources. Also, earlier this year, there was a first global report on infection prevention and control, which included data from the first WHO global survey on IPC in healthcare facilities. So we also reference that and show some of the data from that report. But on the next slide, you'll see I mentioned we have more and more data in the global database. And these graphs show that evolution in data coverage for each of the three reports. The gray bars here are the number of countries that have data, with high-income countries in light gray and low and lower income countries in the darker gray. And on the left, you can see these circles in color. That's the proportion of the population represented by the countries that have data. So for instance, the number of countries that have data on WASH services has increased up to 59 now, but the population represented has stayed pretty stable at 37% because many of the new countries are small, so they don't change the global numbers very much. If you click, Lindsay, you'll see that the JMP makes regional or global estimates when we have 30% of the population represented. So for water, we've been able to make global statistics since our first report. And now for hygiene, we've just got up to 35% of the global population represented with those 40 countries. So I'm very pleased that today we can, for the first time, present global statistics on hand hygiene in healthcare facilities. So on the next slide, I'll show you what those are. We have a global estimate on the right and also estimates for 3 SDG regions and the least developed countries and fragile contexts. In fact, our report leads with hygiene this time. We usually start with water, both because we have a new global baseline and because of the theme of the report on IPC, where hygiene is so central. But it's a pretty bleak finding, I have to say. Globally, just half of healthcare facilities had a basic hygiene service in 2021. And that means it's very basic. It means that they had functional hand hygiene facilities at points of care, and that could either be water and soap or alcohol-based hand rub, and that they also had water and soap at toilets. You know, this is not a very ambitious level, this basic level. We can also see some regional distribution. You can see, for instance, that coverage is lowest in the 46 least developed countries, where only 1 in 3 healthcare facilities had a basic hygiene service. On the next slide, though, you can see that, of course, the COVID pandemic drew special attention to hand hygiene in healthcare facilities. And the report shows a nice example from Ghana, which has a very impressive routine health management information system called DIMS, where they've been collecting data on basic hygiene since 2018, when the global indicators were first defined. And this allowed them to know exactly which facilities did and didn't have basic hygiene services when COVID hit in the beginning of 2020. And then the Ministry of Health acted quickly to reinforce systems in healthcare facilities. They had trainings of IPC focal points. They encouraged the use of simple hand washing devices and making sure that water and soap are available where patients receive care and at toilets. And as a result, basic hygiene coverage rose from 41% at the end of 2019 to 57% in mid-2021. And that's an impressive increase of 40% over just a year and a half. On the next slide, let's turn to water. That's the other service area where we have enough data to make a global estimate. And we can see that in 2021, 78% of the population, 78% of healthcare facilities had water available from an improved source located on premises. And the rest of the population was split evenly between 11% who had limited services and 11% with no water service at all. If we look at regional coverage, you see a spread ranging from 52% in sub-Saharan Africa to 90% in Eastern and Southeastern Asia. And also, again, in the LDCs, just about half of healthcare facilities had a basic water service. On the next slide, there's a big difference between just having an improved water supply and having a basic water service. Basic water services means actually having water available and having that improved source be located on the premises of the facility and not 100 meters away or something. And this figure shows the gap between improved on the right and basic on the left, and those two elements of on premises or available in between. And there can be big gaps. If we look at Iraq, there was a census in 2021 that showed that nearly all healthcare facilities had improved water supplies on premises. But only about in a quarter of those facilities, water wasn't actually available when needed. And we see this a lot where there's intermittent water supply and pipe systems. On the other hand, if we look down at Sudan and Sierra Leone, the biggest gap is about having water supplies be improved and on premises. Because in those countries, it's more boreholes and protected wells, which often aren't located on the premises of healthcare facilities. So that counts as a limited service because really to have all the water that you need the water on premises. So let's turn next to environmental cleaning. That's the newest of the WASH service ladders. It's also very closely tied to infection prevention and control. It's a new global indicator, and in the 2019 report, there were only 4 countries with national data. That's now increased to 21, but that's still not enough to make a global or even regional estimates. But you can see from the countries presented that there are big differences. There are many countries that have no protocols for cleaning, or they don't have all their staff trained on those protocols. And within even one region, there can be huge variability. If we look at Northern Africa and Western Asia, it ranges from universal coverage in Kuwait to only 1% of healthcare facilities in Sudan having basic services. There's an indicator on basic waste management, which has 2 components about having waste segregated at points of generation into at least 3 bins, and then that sharps and infectious waste are treated and disposed of safely. And this scatter plot shows that, the high-income countries, the diamonds, have quite high coverage. But then in the middle and upper middle income areas, you can see a lot of squares and triangles where waste is segregated, but it's not treated. And one reason is that for global monitoring purposes, we don't count burning in open pits as adequate treatment. But that's what happens a lot in lower and middle income countries. But there are also countries like the Democratic Republic of the Congo or Guinea-Bissau where you see there's basically no waste segregation, but there is some level of waste treatment, and that's most commonly incineration into simple one-chamber incinerators. And it's inefficient to incinerate waste that hasn't been segregated because you end up burning a lot of stuff that isn't hazardous. And it's also bad for the environment because at low temperature incineration, you can produce dioxins and furans, which cause their own set of problems. And then last but not least, the most complicated of the WASH services is sanitation. Basic sanitation is complicated because it includes many elements. Not just that there should be usable, improved sanitation facilities, but that they should be available for different types of users. Separate facilities for staff and patients, for men and women, including menstrual hygiene facilities, and toilets that would be accessible to people with limited mobility. Of course, in healthcare facilities, there are a lot of people with limited mobility. And with so many elements, there are many countries that have most of these data but lack 1 or 2 pieces of information. So the JMP will go ahead and make estimates if we have data on all but 1 or 2 of those elements. And on the right, you can see the different elements mapped together. On the left, there's a lot of green. That's because most healthcare facilities have some kind of toilets, and most of them are actually improved. But if you move to the right, you can see that having separate toilets for men and women, for staff, especially menstrual hygiene and limited mobility, the numbers drop a lot. In Kenya, for example, 86% of healthcare facilities had usable, improved toilets, but only 15% provided menstrual hygiene facilities, and only 4% were accessible to people with limited mobility. So now we have basic data on sanitation from 41 countries. It's a big jump from 27 in the last report, but still not enough to make a global estimate. There were enough, though, to make estimates for 3 regions, and you can see that in sub-Saharan Africa, just 13% of healthcare facilities had basic sanitation, and 22% had no sanitation service at all, which means they either had no latrines or only unimproved latrines at the facility. On the next slide, sanitation is probably the most challenging of the 5 WASH indicators, and when countries or regions have data on multiple service indicators, it's usually sanitation that is the lowest. We don't have any regional estimates for environmental cleaning yet, but for the LDCs, fragile contacts, and sub-Saharan Africa, they all look pretty similar to what you see on the right there for LDCs, where about half of facilities have basic water, 1 in 5 have basic sanitation, and 1 in 3 have basic hygiene and basic waste management. If you click, please, Lindsay, you can see there are also 16 countries that have data for all 5 ladders. And in most of those countries, sanitation is the lowest, and sometimes by a big margin. And also in most of these countries, basic water tends to be the highest. And that's just because the requirements for basic water service are easier to meet than those for a basic sanitation service. So on my last slide, I just want to mention that the report gives many examples of indicators that go beyond the basic WASH indicators. We look at higher levels of service, we look at WASH in refugee settings, and the access to different kinds of services for people with limited mobility. Here you can see that from Vanuatu and Kenya, there were 2 data sets that show that a lot of basic services, not just WASH services, but basic healthcare services, are not accessible to people with reduced mobility. There's having toilets, having hand washing facilities, but having ramps for wheelchairs, grab bars on walls. There are just lots of ways in which currently healthcare facilities are not adapted to people with disabilities. So with that, I'm going to conclude this brief tour of the report. Please do check out the full report, which will be on our websites after this session, washdata.org. And you can also download all of the individual Excel files that have the detailed information about data sources for each country and the estimates. We're also very pleased this year to introduce for the first time multilingual country files. So you'll be able to choose if you want to see the data in English, French, Spanish, Arabic, or Russian. So with that, we've got time for a few questions, and we would really love to hear your feedback and any questions. Thanks.
Hi, everybody. I'm Eddie Perez with Global Communities. Rick, as usual, great job and expanding JMP in general has just been great about all this growing information and analysis, et cetera. My question, so JMP is a WASH sector group, and from the beginning, we've all been trying to say, this is important to us, but it should be even more important to the health sector. So I know in my group, I have utterly failed to get my health colleagues to really get very interested in this. How's it going? And so my question is, WHO, UNICEF, others, any progress in getting our health colleagues to use this data, et cetera?
I can start. I don't know if Bruce, you want to jump in, but I would say for WHO, the issue of healthcare facilities, WASH in healthcare facilities, has been transformational in the way that WASH is perceived in our organization. Because, it's very clear that this is core concern for WHO. Whereas sometimes we have to argue that for WASH in communities or households or schools, what's the role of WHO in those settings? But when it comes to having clean water and basic hygiene in healthcare settings, it's very clear. And it's allowed us to build bridges within WHO to other programs. There's a global program on IPC, and for this report, we had lots of back and forth, to understand their data. They understand our data. They're referencing our report. There are other programs around vaccines, around health emergencies, which are drawing on the questions and indicators that we use and adapting them into their monitoring systems. So I would say that the collaboration is getting a lot stronger within WHO. And certainly at the country office level, again, it just resonates with our country offices. I don't know, Bruce, did you want to add anything to that?
Yeah. Does my microphone work? Yes. Okay, perfect. No, I think everything you said, Rick, was spot on. But I also think it's really interesting to always take a sort of the glass is half empty kind of approach as well, just so we're very clear about some of the challenges that remain. And I think when we look at some of the programs that Rick mentioned, like infection prevention and control, and like quality of care, I think within the health community, and certainly I think sometimes within WHO, they themselves feel very neglected. So when we think about pandemic preparedness, we all know, vaccines, maybe a bit of personal protective equipment, therapy, oxygen concentrators, those kind of things were always on everyone's mind. And there wasn't a lot of discussion about basic facility, kind of infrastructure preparedness. So so we do have some allies, and I think we're kind of bonding together a little bit over that. But and I'll be speaking a little bit about investments. But I think there is some way to go, and especially with primary health care, because I think a lot of folks are seeing that is one of the main avenues to carve out a bit of space for this in the primary health care agenda. And there is always a little bit of battle eddy for space there. But I think I think one of the things we can say is we've done, through the JMP, and those, as you sort of rightly said, those figures have been showcased in many health reports now. And through this whole UNICEF WHO momentum, there has been a lot more visibility. But I think we can't kid ourselves. It just and we've had a resolution, at WHO, but it's going to be a long way. And that, I think, is the key question. And we're going to talk about it later because it's so fundamental and there's so many dimensions to it. Excellent. Yeah.
Please go ahead.
Okay. Thank you so much. Yeah, thank you so much. My name is John Akurago, and I work for Habitat for Humanity International. I think the JMP report is really very important for us, and I want to talk about sanitation. When you look at the data, sanitation is always lagging behind. And I think one of the contributing factors to that is the fact that shared sanitation facilities are not considered. But in natural condition, or maybe prevailing conditions, in informal settlements, it is very hard to find access to land to put new sanitation facilities. And so we've had these shared sanitation facilities spread all over, but yet they are not taken into account because they are not accessible 24 hours to the users. So my question is, will there ever be a time where we can have sanitation access being 100%? And if that is not the case, what should we be doing? Because we are leaving out people who are actually having access to sanitation, even though it's not 24 hours. And for public health concerns, disease outbreaks, these sanitation facilities actually contribute. So what do we do as professionals? Thank you.
Yeah, I'll just touch briefly on this because I want to keep the focus on healthcare facilities, but in communities, sharing of sanitation, we classify that as a limited service because of, you said, as the issues about access whenever needed with full safety and security and privacy. But I think we also need to think about safe management of excreta along the whole chain. And we know that there are a lot of sanitation facilities, especially in dense urban settings, where the wastes are not contained, where there's discharge of effluent into open drains and there's inadequate fecal sludge management. So yeah, the issue of sharing is important, but I think even more fundamental for public health is the issue of safe management of excreta in those systems. And if I can just bring it back to healthcare facilities, that basic service level doesn't even get into the management of the waste. It's just about like the users and the toilets. And we know from some of the countries that do go into more detail about healthcare facilities that a lot of those healthcare facilities have non-sewered systems. They don't have adequate fecal sludge management. And I mean, waste from hospital septic tanks is full of all kinds of bad stuff. You don't want that discharging untreated into the open environment. But maybe after the session, we could talk more about households and shared sanitation.
Thank you.
Yeah. I think Tom wanted to add something just maybe before we have a few minutes left.
So Rick, there's a question from our audience online from Stefan Doring. Says, great presentation, really interesting. To what degree are your results available disaggregated by certain countries? I'd be interested to see within country comparison and analysis at that level. Do you want to speak to that question?
Sure. So we always try to disaggregate to the extent that the data permit to highlight, which populations within a country have higher and lower levels of service. Currently for healthcare facilities, the disaggregations that we do are between urban and rural areas, and between hospitals and smaller kinds of facilities, primary health centers and clinics and things. We call them non-hospitals. And between facilities managed through government and non-government sectors. And we see some big differences there, where, as you expect, urban facilities have higher levels of service, so do hospitals. Non-government facilities are often higher quality than, or have higher basic service levels than the government ones. We're not yet able to look into subnational distributions, but we can reference the individual data sources which may be able to do that. You can see what the data sources are in those country files, but we don't yet show the full disaggregation by subnational region. We're starting to do that for WASH in households, and I think eventually that's our vision to do also for healthcare facilities, but it'll just take some time.
Great. Thanks so much, Rick. So we'll invite Bruce to come up and share insights from the study on costing universal healthcare facilities access in the lowest, the 46 least developed countries. So over to you, Bruce.
Okay, thanks so much, Anne. And thanks everyone for being here. So we saw from Rick that you've seen the latest figures on WASH and healthcare facilities, and that's tremendously important. And of course, and Rick will be doing some media with his UNICEF colleagues this afternoon, but the question always is, what can we do about it? What are the costs? What's the political will? And so I'm going to try to talk a little bit about that. You saw some of the figures. I don't know, Rick mentioned one report called Fundamentals First, which was the last update we had. And there was a costing, a preliminary costing of what it would, the investment required to meet universal basic coverage by 2030. And this is a new Lancet paper that is an update on that. So I can tell you a little bit, walk you through what the key differences were, but the costs remain modest. So the next slide, please. So of course, I think, it goes without, well, it may not go without saying, but I think many of you are the converted, preaching to the converted, but maybe some of you are new to this. But obviously, when the first figures emerged globally, including through the JMP, there was a lot of alarm. And I haven't met a single sort of person that isn't surprised and shocked when they hear this for the first time. And so in many ways, when this costing study was being kind of formulated, I was of almost two minds about whether it was worth it, because in many ways, this is non-negotiable stuff. And for us to be able to say, well, we want to convince you because it's affordable, it's a low cost, at sort of some point, it's sort of saying, well, why should we convince you in that manner? Of course, all this stuff is required. We do have all these, I guess, initiatives as far as a global task force, a World Health Assembly resolution, and we know that we need more investment. But at the end of the day, this added kind of granularity of costs about, this is actually very achievable. It's actually very modest. We've benchmarked these against other costs. We felt that was also an important addition to the evidence base. So that's what I'll present. Next slide, please. So the scope of this study is the 42 least developed countries defined by the UN. And what we tried to get a sense of was what the costs were associated with capital or infrastructure investment. And that is all kind of determined by what Rick presented on the JMP criteria. So what does it take to get to a basic water service? So getting connected to a network or getting an on-premise water supply. What does it take to have those sanitation facilities that meet basic? And what does it take? And again, when we think about WASH, of course, we think also about hand hygiene. So hand hygiene facilities, whether it's a basin or whether it's alcohol-based hand rubs at points of care, both at the point of care, but also at a toilet. So those are important, but we also looked at healthcare waste management, which is interesting. We included it. It's part of the criteria, but it's also sometimes expensive because of things, as far as waste treatment. So incinerators, for instance. And then the main data from this report comes from our colleagues at UNICEF, who went and arranged for data on these costs, their estimate of costs from government counterparts or from project implementers, to get us some understanding of what these things cost per facility. Next slide, please. So the data, the coverage, of course, is from this Lancet article, which is available, and there's a lot of detailed annexes if you're interested in digging into it. Is using, of course, the previous JMP data, so in 2019, representing 2019. And in that case, in these LDCs, there was 50% basic water supply, so half of the facilities were without water. 37% had sanitation, which is a little bit of a higher bar given the more criteria associated with it. Hygiene was a little higher, and waste management was very low for 2019. And so again, I mentioned the capital cost, and then the recurring cost. So some of this infrastructure requires repair. One of the reasons that this cost estimate is higher than the previous was that we had some better data about when things essentially need to be replaced, when infrastructure needs to be replaced or upgraded, and that was caught within this 10-year time period. Next slide, please. So that's the figure, like this overall figure of 6.5 to 9.6 billion. And that's an interesting figure. And for all you people out here that think in billions and global kind of investment, I'm not sure how many of you are, but it's interesting when you talk to the World Bank or ADB or others, these kind of billion figures are not, I'm looking at Shoma, they don't scare you. They scare me, but I don't think they scare you, because the portfolios of development aid and even government budgets, as we will see in subsequent slides, are capable of actually meeting this. And you could see that there is about a similar amount required for the recurrent annual spending as there is for the initial investment. Next slide. And that is just sort of projected out over the years. So this started in 21, but you can see that there's reasonably constant infrastructure, the assumptions on infrastructure investment. And as the infrastructure kind of became greater and greater over time, of course, there was more and more investment required to keep that in service and replace it. So then you can see in the light gray, the operations and maintenance and repairs and everything else growing over time, with the investments a little bit, the infrastructure coming down. Next slide. So, I mean, this is always interesting to dive down to the country level, because if we want to make a dent, a big dent, and a dent, I shouldn't say 80% of our worldwide need for LDCs, but if we considered that if we could just focus on 10 countries, we would be helping 8 out of 10 people that are more vulnerable now to infections and dignity and all the things we know are associated with this. So you can see, some in Africa, some in South Asia, and that's generally, where the investment needs to go, and of course in fragile contexts as well. Next slide, please. So this is the benchmarking thing, and I'm always just personally curious about how people interpret these figures, because we can say, okay, and I'll walk you through it, but per capita, you have, these figures are per capita per year, so the amount of money that a person would, or associated with each person, would have to invest, or the government would invest it, but for each person, it would be, a kind of almost 80 cents, per year, upper range estimate required for each person. And that's okay. So what does that mean? Is that expensive? It doesn't seem so expensive. And then you start looking at the amount of money that is required for universal basic wash. And so that requires getting up towards $12 a person per year. And then $10 per person per year is the recurrent health spending per capita that by the 44 least developed country governments in 2018. So that's overall health expenditure. So this sort of 50 cent to 80 cent piece associated with that. And then you start looking also at the per capita expenditure on wash, total wash, so household wash, getting up to $3. But the thing that I find really interesting about this slide actually is not all those figures. I don't know if you can see it, but it's this 80 cents. And that's the capital health spending per capita. So this is what governments are actually spending on their capital health spending. And so it actually is quite, when compared to that figure, you start thinking, well, actually, someone's going to have to make some tough decisions, and there's going to have to be some good political will to make this happen. Next slide. So just diving in a little bit to the results, you can see that waste management in the sort of pink and red dominates by quite a bit. And that's, as you remember you may remember from the previous slide, there's quite a bit of waste treatment. And when I say waste treatment, we talked about sanitation, and I mean medical waste. So being sorted into bins and being incinerated if that's required. So that's quite a bit of the cost. And sanitation, of course, was spoken about earlier, and it's also dominates quite a bit of the cost as well. But I mean, there's much needs to be done in hand hygiene, and those costs are reasonably modest. Next slide. So again, this is looking, and the second reason this figure is higher than the previous is that when we were counting facilities, we had a better count of those sort of rural facilities that did not have many services. And when we got a better understanding of that, then of course the numbers were brought up quite a bit. And those again dominate, as you can imagine, because that's, as you saw from the opening videos, when you have small rural clinics, you may not have facilities with WASH, of course. So they, and just to say, and I've had a discussion with the authors and Maggie Montgomery, my colleague, who is not here, but another thing that isn't on the slides is she was sort of saying for a smaller rural facility over the 10 years, it would cost about $20,000. And for a larger facility, kind of hospital, more like $100,000. But if you start dividing that up, that just gives you another sense of what's required. Next slide. So a lot of text here, but again, I think I've tried to emphasize to you that the costs are modest compared to the overall levels of health and WASH spending. The other message is this need to budget recurrent spending. So it's not to overwhelm people, but it's just to say when governments put their budgets together, or facility managers, it's very much that if it's this recurrent spending isn't budgeted, then we're sort of shooting ourselves in the foot. And as I just said, the needs are greatest for facilities in rural areas and in, quote, non-hospitals. I like that term. It's always made me scratch my head, but you can blame Rick and Tom for that. And finally, that even with this recent, I mentioned we did do a costing in our last report, and that's already had some impact as far as influencing country roadmaps. And also really brought, I think, a little bit of attention to funders like the Global Fund and some of the COVID work that we saw. Next slide. So again, what does all this mean? I think that if there's one thing that we would love this information to be kind of absorbed and considered is that when our health financing folks, and you mentioned this, Eddie, like they need to budget for this, right? And so it's getting this into budgeting systems. And that's another discussion we haven't really talked about so much, but we've had a tremendous amount of contact, both within WHO and UNICEF, but with our health financing colleagues, to sort of kind of get them, advocate them to kind of start thinking about this when they're doing the health financing work. Of course, pandemic preparedness and future pandemics, this is key and central to that. And we've been having ongoing discussions about this, and hopefully donors will, there has been, I think, some reaction, good reaction among donors and great political leadership, so we thank them. And I guess the last message, it's not necessarily something I've explicitly talked about, but some of the sensitivity analysis in this study looked at essentially discounting or some of those infrastructure investments that would deteriorate more quickly because of climate risks, that was considered a bit. And the main message here is that we need to invest in climate resilience from the outset. It's a lot cheaper. So, and some of this is quite, it's not overly complicated, but I won't get into that. And the next slide, please. So the next slide is thank you, like really thank you. I didn't know what the next slide was actually, but thank you very much.
Excellent. Questions?
Thank you. This is Sonia. Andreas from Water and Sweden. Thanks, Bruce. I have an idea. Why don't we lure the finance ministers to the World Health Assembly? I was there in May, and well, I met you and Rick and others there. I do feel that there is a lot of support when health ministers and so on are there. But it's like when they're going back, they have to sort of break a leg to get the money which is really needed. So, of course, that's not doable. But I also know, I guess, I don't know. But also I know that I know my colleagues in the UK are really struggling for G7, G20 to get WASH and WASH in healthcare facilities, IPC and all that stuff on the financing agenda, which sometimes succeeds, but sometimes don't, and most of the time don't, I would say. And also I'm a bit worried because of the healthcare resolution, WASH in healthcare facility resolution you mentioned. It's about to end next year, isn't it? Yeah, so that will be sort of the last time that will be reported. What happens next? What happens then? The global task force, isn't it supposed to end this year, or now it's been prolonged to next World Health Assembly? So if that doesn't exist, if we can't do the homework ourselves, how can we sort of make others, like the finance ministers, to really invest in WASH and in WASH in healthcare facilities, in IPC. We have the pandemic preparedness resolution, which I'm not sure is going to be that detailed, and so on and so on. I think you get my point. We need the finance ministers along, basically. How can we do it?
Yeah. Wow, no, it's a tremendously good point, and there's a couple elements maybe I'll pick up on, and I think the first is, as you kind of pointed out, like we had our resolution in 2019. We've been since then tracking progress of countries to implement the resolution and trying to provide a little bit of that sort of accountability. Has there been roadmaps? All these things. As you say, like 2023 is our last official report back. And report backs to the World Health Assembly can be meaningful, or they can be sort of, a 2 or 3 pager that maybe is not that maybe like somewhat neglected. So I think we need to make the most out of that. And I don't want to. One thing I don't want to over-promise anything with the World Health Assembly, because you get into governing bodies, you get into politics. There's a lot of things out of your control. And as soon as you would say something like finance ministers, there would be a bunch of other health folks elbowing their way to get attention. But having said that, I do think that there's a feasibility to get maybe potentially some health or finance ministers maybe to a special event that maybe could do some commenting on, but we'll need your help. We'll need the WHO does not, many organizations are like this, does not work so well through internal advocacy. But if we get WaterAid's help, the World Bank's help, and member states themselves saying we want to talk about this, then we could work behind the scenes. I guess this is being live cast, so anyway. Strategize. I'm really sorry, everyone at WHO, but anyway. Sorry.
Otherwise, okay, so we'll take one more from the room,
Okay.
and then we have one online.
Thank you to you both, and this is sort of maybe a tangential question. So sort of the health side waste management, where you said this is the lowest coverage. Are there good resources? If it's only, I think you said $10,000 maybe for a rural hospital. So I work with a group. I'm Seth with Water Mission, and we do a lot of work in Tanzania, and obviously that was one of the countries on your 10 most in need. But it's tough for I think a lot of the WASH professionals. $10,000 we may be putting $200,000 into a water system in a rural community isn't that large of a leap, especially when we're putting access points at the local clinics. But it's tough for us to visualize maybe what health waste management looks like, to plan about. And sometimes it's easier for us to add on a little bit, but if we can't think, we don't have resources to really finance. That'd be my question. Where is the place to find some resources to help us visualize what that may look like and what the operation may be to help us start to plan for it early on as we're seeking funding and project planning?
And I think, others might want to join because it's a good question. And I know I think some of my colleagues from infection prevention control are maybe on the call as well. But I do think this is one of those things where, where does waste management fit? Even, within WHO, there's a little bit of, I have a bit of it and someone else has a bit of it. And so it's certainly something that requires a lot of coordination. And I just think it would be a tremendously good idea, and we could help kind of point you to, some of our colleagues at WHO, at the country office, and maybe others, but to get some of these facility managers and some of the health sector people to work with you. So you're like, we can help get the core WASH systems, put into place. Waste management, will you work with us? Maybe we can provide some funding for some of the, kind of treatment or, other things, but we need to do this together, and we need a kind of joint commitment if you want to get infection prevention and control sorted out within your facility. But that is another, because I think it's on us also, when I say us, generally a WASH community here, to reach out to our health colleagues and say, we're going to do something about it, but we need to, it's a good opportunity for advocacy as well, for sustainability. It's a good question.
Yeah, and if I could just follow up on that. I think there are resources available about different technologies for healthcare waste management. It is a neglected area, but there are also low-cost technologies available. I think there's a lot of interest in non-incineration technologies for environmental reasons. So looking at things like autoclaves, which don't have to be very expensive. You do still need safe disposal after that, but you can at least address the infectious wastes. But even before that, I think just better focus on segregation is key to reducing the burden of healthcare waste management. Only about 15% of healthcare waste is actually infectious. So if you can have good triage systems, then the waste management becomes a lot more manageable. Bruce, I've got one question from our chat. It's coming from a Rolf Luyendijk, I think is his name. Yeah.
I'm just kidding, Rolf.
And no, Rolf's an old colleague and friend, but he asks about the financial stuff, and I'll just read out. He says that while the per capita costs seem low, did you benchmark this to overall investments in health in a country? So the entire health services in Afghanistan used to be run at less than US $7 per capita. And while this by far was not enough, it was what was available, largely from overseas development assistance. And the WASH and healthcare facilities per capita numbers that you've cited are very significant in that context. So let me pass it back to you. We say 70 cents per person per year is not much, but can you put that in the context of what countries are actually spending on? And
I have my microphone. I don't know where the slides went, but that's what I was trying to kind of get at with that one concern I had, where I kind of mentioned there was one small dot, and it was kind of trying to represent the global kind of, or I don't know how many countries, but it was aggregating about, I think it was, it was aggregating 23 least developed countries in their capital health spending, and it was benchmarked to 80 cents. So I did kind of acknowledge, Rolf, that was, if you look at it like that, it is somewhat significant. So I think we have to consider both sides. I don't think we can just sort of throw it off and say, okay, budget for it. It's not anything in comparison to your health budget or spending. It is, but at the end of the day, it is somewhat achievable. And I think some of the benchmarking, I'm not sure, but if you look in the annexes of the report, you can dig out some country-specific information, although I'm not entirely certain if we have that Afghanistan figure. Thanks.
Okay, thanks so much. Bruce, I think it's time for you to convene our panel of experts.
Okay, so now we get to hear thank you so much, Rick, and I'd like to call up our panel here. So we have Shoma Ghosh from the World Bank. It's been so wonderful working with her and her colleagues on this initiative on healthcare facilities. We have Rod Beadle for Food for the Hungry. He's done a tremendous amount of work on implementation and training. And Thomas, who opened the session from UNICEF, and Lisa Rudge from FCDO, the United Kingdom Aid Agency. So I don't know how, do you guys, I think we're missing one chair. Let me get you a chair. Yeah. And I don't know if maybe we can move them forward so your back isn't hitting the screen.
Yeah, and if you can just have people use the microphone.
So I think what I'd like to do, so there was a lot of really good questions that we heard, and I think some of the questions, are very relevant, and we kind of anticipated them because they're some of our biggest challenges. And maybe I'd like just to start with Shoma, and maybe just to introduce you. She's the practice manager for the Water Global Practice in East and Southern Africa, and she's been an advocate and implementer of WASH in healthcare facilities. And in her most recent assignment, she's managed the global unit in the Water Global Practice. You've really elevated WASH in healthcare facilities, and I'm sure it's one thing among many that you're doing, and delivered that knowledge throughout the bank operation. So thank you so much for that. So you saw the costing study, and it sort of is suggesting, hopefully people got the impression the costs were modest, but we know that there's some tremendous gaps, and we need to kind of find and mobilize and allocate funding. And I'm just wondering from your perspective if you can help us a little in that journey.
Well, thank you very much, Bruce. It's been an honor to be here and to be part of this group pushing for a very important agenda on WASH in healthcare facilities. And we have seen this during the pandemic, how important it is. The challenge is now it's palpable, and it is much being recognized that every healthcare facility deserves functional WASH systems to make it a resilient health system. It's more of a systemic issue. I would start by saying that if you look into the water sector, I'm a water professional, and if you look into the water sector, if you see the kind of budgets the allocations that are there in water, it is underinvested. It is undervalued, and at the same time, it is poorly managed. So we are building up a WASH in healthcare facilities from a premise that we have a broken system. And within that, how do we make WASH in healthcare facilities work? However, the pandemic actually, including with the climate shocks, is making it more challenging, even for the WASH sector, to provide services to its households, to the communities, and even more so in the healthcare facilities. But we cannot neglect the healthcare systems. So how do we advocate? Where do we need to? Where do we start from? So we started, thanks to WHO, UNICEF, and all our global partners to push this agenda inside the bank and start looking into our own portfolio. What are we doing in WASH in healthcare systems? How can we make our health colleagues more, just not awareing them about that WASH is needed in healthcare facilities, but to make them commit to the investments in the healthcare, in the health operations. So it started with a very small exercise by looking into our own portfolio, and we found out that 23 countries across 6 regions, in fact 23 projects across 6 regions, there is investment in WASH, and it was not a small amount. It was tuning to around 3.76 billion. So that's not a small feat to start with, right? But that was not enough also. Even if infrastructure is being created, how do you make it work? How do you see those allocations are actually flowing to the healthcare services? And do they have enough technical technical assistance and technical support to implement it? So that helped us to ramp up inside the bank, the water practice along with the health practice and our nutrition colleagues, come together to look at that how we can actually divert some of our water and sanitation investments towards healthcare facilities. So with that, within a year, we have ramped it up to 53 projects, which means 53 operations across 53 countries. So that gives us enough information about what is happening in this sector. So which actually, if you see it in a 2 years' time, we saw that we could ramp it up to from 3.76 billion to 5.86 billion. That's not a small amount. But the key question is that it's fine that we are investing here, but how do we make it more sustainable? How do we ensure that these investments are needed? As you mentioned, that it should be part of the finance minister's it's just not about finance minister's briefing, but the allocations, the budgetary allocations that are needed. So we looked into 3 specific areas. One is start the national advocacy along with everyone to ensure that there is a clear and sustained financial allocations, budgetary allocations made in public financing. The cost actually helped us to see that what kind of estimates are needed at the national budgets and health, and ensure whether it should be, those allocations should be sitting in the Ministry of Water or Ministry of Health. If it is with the Ministry of Health, what kind of services, what kind of technical advisory services do the Ministry of Health therefore need to ensure that those services are sustained? Secondly is, even within the water sector, it's important to see the utilities are extending services to the healthcare facilities in the urban areas and in the rural areas, of course, looking at where you can coordinate better on the health and the water budgets. So we look at the subnational level. Thirdly is, again, looking at, while we are looking at public financing, I think it's time that we should also go out to the market and look for commercial private financing. If there are private sectors, selling soaps, then why not extend services for water and sanitation in healthcare facilities? I think it's absolutely important at this time. So we should look at what is the capital financing available in the market and why not mobilize the private capitals here. I think we have got enough. We have seen that Xylem and Suez and Unilever, everybody is here. Why not call to action to the private sector to see that make concrete investments in this sector. The other area was our internal advocacy, making WASH in healthcare facility as a concrete pillar in the health, nutrition, and population strategy in the bank. I think that's where we can drive just not the policy dialogue, but also committing to the investment that is needed here. So that's second area. Thirdly, that we also see is there are a number of multi-donor trust funds, and leveraging these trust funds like internally in the bank with us in the water supply and in our water practice, we have the GWSP multi-donor trust funds. We also have in the bank the global financial facility for women and adolescent areas. Converge and look at what kind of technical assistance therefore needed to ramp up, to help the Ministry of Finance to actually get into the granular details of making budgetary allocations and committed. The other area that we have seen, it makes a lot of, it is all about learning by doing. And so we started it with our own projects. You've seen the Tanzania video today. It is part of one of our water supply and sanitation, national water supply and sanitation project, but we have a very concrete result area on extending healthcare facilities in the rural areas. So, of course, it is driven by results, so which means that facilities are just not being provided, but they are being functional. So there are around 2,000 healthcare facilities that are now got WASH services. Similarly, there is also another national program, which is the Nigeria Rural and Urban Water Supply and Sanitation Program. It is also a results-driven program where 10% of the funds are allocated for healthcare facilities. I don't have to say much about the India Health Mission and Swachh Bharat Mission, which actually shows convergence of funds. And looking at the rural areas and even in the urban areas, but more interestingly, we looked into the rural areas and seeing that if you are making open defecation-free villages that are functional, part of the protocol of the assessment was to see that there are functional toilets and functional wash facilities in the primary healthcare centers, which allowed to receive awards by the rural local governments, and it was not a small fee. It's not a small number. In fact, about $1.5 billion, the national, the World Bank's project, 80% actually went to those to the open defecation-free villages, which actually had 30% to cover for healthcare facilities. So the numbers are good. I think we have the evidence that we can take it to the larger extent. Finally, I would just like to say that we will not be able to manage unless we know what we are measuring. So Keith, thank you very much for providing the data that will drive us home what is the investment needed. And I really liked your point about convening the finance ministers. I think we should be ready for the next spring meeting in the bank, where we can actually convene a session on healthcare facilities, WASH in healthcare facilities. If we want to drive this message home, we have to make the finance ministers commit to it. Thank you.
So there we go, because we talked World Health Assembly and bringing finance ministers there, but bringing some health folks to the World Bank spring meetings, ooh, Shoma. Wonderful point, but many things to explore, and we're, I don't know, it's actually, I was going to say, feel grateful to the World Bank, but also relieved, because the portfolio of work you're talking about is just, you have these access and knowledge that is very unique. So I'm going to shift now to Rod Beadle. You're the Global WASH lead for Food for the Hungry. And I've just realized we're a little short on time. I have 2 paragraphs of all the wonderful things that you've done in very difficult situations, helping people in need. And I hope it's okay if I don't go through that. But you can see the person in the ball cap there is the implementer. And so what I would like to ask you about is, just in all your experiences, training, implementing, and using, for example, the WASH Fit tool, which many of you may be familiar with, but it's a facility improvement tool. When you look at sort of deploying that, and I know that there's some innovative issues like new digital versions, have they improved the efficiency and effectiveness of collecting, sharing, and utilizing data to inform interventions? Can you speak a little bit to that, how you're using this data and tools? Thanks.
Sure, and I know we're short on time, so the answer is yes. But we work with the WHO and Engineers Without Borders to develop digital versions of the WASH Fit tools. Initially, we did so in recognition of the connections and critical nature of WASH in healthcare facilities in the context of preventing the spread of COVID. So we modified the WASH Fit and input it into a program called Kobo Toolbox, which is a free program that is a data collection platform. And we shared that with WHO, and that was shared worldwide and used pretty extensively. And then earlier this year, with the release of WASH Fit 2.0, we also developed a full version of the Kobo Toolbox to accommodate assessment of healthcare facilities with all of the elements of WASH Fit 2.0 incorporated into that. And that includes feeding data that aligns with the JMP. The reason that we focused on doing it digitally is that the program is able to collect data using smartphones, tablets, laptops, things that are readily available throughout the world. And you're able to collect the data without necessarily having a data connection at the time. So you can upload that data when you do have that connection later on. Also, very importantly, you can take pictures that are linked to the data their geo-reference pictures, and most of the data collection, like a mobile phone or a smartphone, is going to have GPS in it, so that you can also collect data geospatially, and you can analyze that data geospatially. Also, very important with the WASH Fit tool is that there is a scoring of the different areas that you evaluate, and so you can compare the scoring in different regions and different types of facilities and even in different countries to better recognize where the needs are and where best to spend your resources. So, and then finally, maybe the most important element is that by collecting data digitally, it's consistent. It doesn't depend upon the enumerator's interpretation. And that data can be shared with other organizations. It can be shared with ministries of health. It can, again, be fed into the JMPs. Just a lot of things that you can do digitally that you can't necessarily do when you're just filling out forms and relying on manual input. So, yeah.
Thanks so much, Rod. And I mean, it's a really nice kind of segue into, well, maybe I'll introduce Anne, and you've introduced yourself, but I would like to say Anne is a senior WASH advisor at UNICEF with an ever-growing number of portfolios. Sanitation, hygiene, healthcare facilities. But Anne, it's great, obviously, that you're here. And Rod spoke a little bit about sharing data, and I wanted to ask you about national monitoring and accountability. So the question is, what's been your experience with these issues, monitoring and accountability of WASH in healthcare facilities, either nationally or subnationally? And I wanted to mention, many of you know that Anne was the chief of WASH in Indonesia, so has some really nice insights there. Over to you.
Great, thanks very much, Bruce. And yes, so I'll be wearing my hat a little bit as the chief of WASH of Indonesia now. But, you know, we had some really interesting experience with healthcare facilities. And, you know, this sort of headline story in Indonesia when I was there was that under 5 child mortality was coming down dramatically with improvements in immunization and WASH services, but neonatal mortality was stagnant for the last 2 decades. And there was a very strong feeling that this was related to the lack of good WASH conditions in healthcare facilities, but we had no data. So UNICEF in 2018 undertook this baseline on healthcare facilities that included over 50,000 healthcare facilities ranging from sort of the more formal public health centers to sort of less formal structures at the village level. And basically we came out with, you know, that about a quarter of the public health care centers didn't have the full WASH suite. But then when we looked at the smaller structures, that it was over 50% that didn't have them. So, you know, it's a really shocking situation. And it also masked disparities across the country. So in Papua, you know, the far west part of the country, far east part of the country, it was the worst. And, you know, in parts near Java, we had some of the highest coverage. But still, it really gave us a lot of food for thought. And so what did we do with this data? You know, how do we use it as sort of the story here? One, you know, it really ignited a lot of discussion within the government. And we realized that there were directorates within the Ministry of Health that had competing mandates for WASH and health facilities, but no one was truly responsible for it. So we realized there was work to be done to engage the different directorates in discussions to try and resolve this issue. But more importantly, it had to come from the minister herself to help rectify who would be in charge of this. So that was one big piece of the puzzle. A second was in trying to cobble together the data, we realized that the data sat in multiple sources, and we needed to strengthen the National Health Information System. So that was sort of a second. And then a third was, you know, where do we start? This is a really daunting task for the government now to do something. And one of the opportunities that we saw, similar to what Soma was saying about, you know, performance-based, is that the National Health, the Ministry of Health had an accreditation system for healthcare facilities. And so almost like a benchmarking of, you know, things that had to be in place to kick in a financial payment to the healthcare facilities. So we started the initial discussions about putting in place some WASH service indicators into that accreditation program to allow government to start making incremental changes in the program. So overall, the link between the data and strengthening systems within the government, but then also giving a starting point for how to make and affect that kind of change was really valuable and important in that country context. So that's my input for this for this session. I'm wearing that hat.
Thanks so much, Anne, for adding yet more insight into this issue. And so right now, I think it's exciting. We've been waiting for Lisa Rudge to speak because she's going to be answering one of the questions raised earlier. But she is a WASH advisor with the Foreign and Commonwealth and Development Office of the UK. And let me just say that there's a number of bilateral donors, including my colleague Ilva from CETA, and others that are participating in a global task force to promote WASH in healthcare facilities, and kind of speaking to some of these questions that were raised earlier about, how do we get this international coordination to work? And so we'll continue to work on that. So we have a plan up to 2030. But so you've been involved in this task force, and I don't need to say more about the question because I think we all know we need to get the health sector to take this seriously. We need to work with them in terms of planning and budgeting and on technical cooperation, but there's immense challenges. So what are your thoughts on all that?
Great, thanks, Bruce. So some of the questions obviously already raised this. So firstly, I just want to start by saying that actually, I think all of this that we've spoken about, the baseline reports, the data is absolutely critical in bringing this to the health sector. Health sector colleagues like data. They like to know what deaths can be avoided. They like to kind of have that evidence. So that's really important, firstly, for just keeping that on the health sector's kind of radar. I guess from being part of the WASH and Healthcare Facilities Task Force and from our collective experience, there's a few pointers here. But first, let me just go through what we're doing in the UK. So I'm part of the Global Health Directorate. So I do talk to my WASH colleagues about WASH and healthcare facilities as often as possible. And a couple of things. So we have a health system strengthening approach paper that was launched in December. And that really it's really important that took into account WASH and healthcare facilities as a basic service that's needed to not only improve primary healthcare, but also achieve universal healthcare. And we mentioned poor quality of care, but I think the pandemic, together with all of this information, really helps our health colleagues to understand how important WASH and healthcare facilities is, and that it is part of the health system's kind of mandate to finance and include that in the budget. And we mustn't forget that, but we mustn't either forget to talk about it with our health colleagues. Just before I talk a little bit more about talking about it, just to say that we also have a new approach paper also launched in December around the ending preventable deaths of mothers, newborns and children. And WASH and healthcare facilities is part of the third pillar of that, alongside health systems strengthening and others. So it's possible these have to be included in national strategies and policies in order to be then budgeted and planned. So that's the first step. I talked about talking about it. So yes, G7 and G20, absolutely critical that we continue talking to people who are planning for those sessions. As a government official, obviously I brief people, I include it in briefs, etc. This has to be done all the way down the chain at country level, and we do all have to rally together and make sure that that's done. And I know WaterAid do a great job at making sure that that is included. So that's absolutely critical. And it's not just kind of universal healthcare. You mentioned pandemic preparedness, treaty, vaccines, all quality of care and infection prevention control, and antimicrobial resistance. And we really need to make sure that this is included in those kinds of discussions. Measuring progress is absolutely essential. I think this is why we're all here today, so I won't go into that. Just in terms of of planning and budgeting. So one of the things that's said in our health system strengthening paper is also that coordination is absolutely critical, and working through multilaterals, and also making sure that, you know, we can often be siloed. So we fund disease-specific multilaterals to implement, but, you know, we really need to sit around a table at a country office level, or at a country level or district level, to make sure that all of those funding streams are coordinated, and the roles and responsibilities of each of us, of us, the funders, the implementers, etc., are clearly defined, so that budget lines are, you know, in the GFF, in Gavi, etc. They all somehow take into account WASH and healthcare facilities. So there's no extra cash at the moment, is there? But we know that some cash is there. It's about who is putting in what and where, and I think that's really important. I'm going to finish on 2 points, but it's also an issue of gender equity. We really need to make use of that. So we know from the White Ribbon Alliance that women in countries really want WASH and healthcare facilities after respectful and dignified care, and that, to me, is really, really critical. So let's make sure that women who sit on, you know, in communities, who sit on community healthcare committees working with the healthcare facilities at the local level, that they have the voice that they need in order to, or that they have the voice and that they can make sure that that does get on the budgeting kind of priorities of the healthcare facility manager. My last point is around climate financing. So we're working very climate with the WHO and many others, and on climate resilient healthcare facilities. Climate resilient, but also low carbon WASH and healthcare facilities. I think this is really important, that there's 60 countries that have already committed to that through their national action plans. There's a real opportunity here to make use of that funding stream. Are we making enough use of it? How can we do that better? So there's the WHO, the UK and others have launched a facility called ATTACH. It's not a facility, it's a coordination mechanism to share know-how and to kind of build capacity, and ultimately so that we're better at kind of channeling those climate funds into WASH and healthcare facilities, and into healthcare facilities more generally, looking at energy, water and other things, but also we need to make sure that WASH and healthcare facilities is on that agenda. So I will stop there on that note. Bruce, thank you very much.
No, I mean, well, let's thank the whole panel. There's actually a lot of, well, A, a lot of amazing insights we'll follow up on, and B, a lot of hard work. I see we have 3 minutes left, and I know you were thinking about concluding, but just before you did, we have, so 8 years, yeah, left before the SDGs. And I just wanted to quickly, if there was a one-line answer, and you don't have to answer, but did you feel, if you wanted to boil it down to one point that may have been omitted or that you wanted to stress? Is there anything that we haven't covered or that you would like to stress? Shoma,
It's data evidence.
Yeah.
Drive the data home to ensure there are budget allocations done.
Perfect, thanks. Rod, you got
Yes.
I think that's good.
Yeah, okay, perfect. Over to you.
Okay, so I think because we have 3 minutes, I have 3 points to try and summarize all the great information that was shared today in the discussion. The first, is this discussion around how do we really catalyze high-level political action on this? And we had some really great discussion and a great suggestion of gathering the finance ministers next year. So I think that was something that, if we really want to elevate this, we need to get governments involved and get their attention on this. So I think that's something we can take forward. A second was around how we link the WASH and healthcare facilities agenda within the health sector. And we talked about how this is really a transformational agenda. And we really need to embed WASH services within health system strengthening agenda, and that's really important to keep talking about it. And we, with COVID and pandemic preparedness, these are some of the levers that we can lean upon to try and affect some of that change and embed it within the health system. So lastly, we talked about making change on the ground, and how do we use the evidence and embed evidence to drive action and learning on the ground. So I think that was one of the key things that we need to keep learning from each other on, and supporting the countries as they make this progress, and really addressing quite a monumental challenge going forward. And then finally, just to say and to reiterate Rick's words, that the new JMP report is available now. I believe it's available now, right now. So you can all dive into the data. And I just wanted to thank you all, wherever you are, for joining us today. I think we had a very successful hybrid event and good participation both from hybrid and in the room. So thanks very much, everyone.